Coming to you live from downtown Washington, D.C. Those who are on the computer at home in your pajamas, the rest of us got dressed up and decided to dust off the old ties and suits and nice outfits to come together for our 12th annual Ruesch Center, Fighting a Smarter War Against Cancer. And I really appreciate everyone for making the effort to come together this morning and for our entire day of activity. Just to give everybody a sense, there was a year last year. Does anybody remember it? We did have an 11th annual Ruesch Center Symposium, and it was all, of course, virtual. And we thought that it was appropriate to do our best to hybridize this event. So we have about 100 people who have registered to come live through the course of the day. And there are about 150 people who have registered online for our two-day event. As just everyone knows, today is primarily, as I say to our patients, for the white coat side of the formula, where we're going to really try and do a deep dive into some of the key scientific elements of our GI cancer world. The afternoon, each year we try to pick a theme that is not only topical, but important to advancing our world in GI cancers. And this afternoon, we have an incredible program that really focuses on the racial inequalities that exist particular to GI cancers. And we have quite a good faculty for that. My name is Dr. John Marshall. I am the director of the Otto J. Ruesch Center for the Cure of GI Cancers from Georgetown University. And on behalf of our entire team, we really want to welcome you to this annual event that we celebrate the progress and the new science that is going forward in a group of cancers, which clearly are the most common, most fatal group of cancers on our planet. And we need to do better. And that's what we're here to do, is learn from each other. This does not happen without an incredible partnership, first starting with our own Ruesch Center team, Craig, Kristen, Marion, and others who have been so critical to making this happen from our side, and then our partners with the OncLive PER team and all of their tech and abilities to pull something like this off. They are best in class, and we are delighted to get to partner with them on this. So we appreciate all of their assistance and support. With that, I'm going to give just my usual few introductory comments about where we are and what we are doing. The Ruesch Center was founded. Jack, you just missed my really nice shout out for you too there, man. Welcome. The Ruesch Center was founded with the vision to really cure every patient with GI cancers. And this is a bold statement and a bold goal, but I think it is what is expected of us in the medical profession. And I think while survival counts, cure is what people are after. And so we're going to continue to do that. And our mission is to integrate the scientific discoveries with a patient-centered philosophy. We do have a little bit of a video that we'll open after lunch sessions with that focuses on our take on what exactly that means, patient-centered philosophy. We've been busy. As with everybody in our world, cancer has not been elective. We could not turn off the business of cancer care on March of 2020 and just wait and see what happened. We had to keep it alive. And our team in particular were drawn in two fronts. We had to both face the patients that needed the cancer care, but on the back end, we had to help our colleagues at the hospital who were caring for an increasing burden of COVID patients in all of our hospitals. So we had to turn our attention two directions. And we are very proud of the work that all of us did. It was an all hands on deck 6 to 12 months, really, where everyone chipped in. But we were still really a very productive year in terms of the science that we put out, with a high number of publications and a higher impact. The number of new patients that we have seen continues to be high. I will say that the worry that patients were going to come with later stage disease because they were not getting screened came true. So we are seeing this big rat through the snake, if you will, of patients over the last 6 to 12 months of people who were not getting their routine screening, who came at a much more advanced stage. So that indeed is true. We continue to participate mostly from our basements in our pajamas in virtual events, but we continue to participate in those, and we continue to support research, innovative research. We've been thinking a lot about this concept of incremental research. You learn another step, a basic understanding of cancer biology, coupled to long bomb, high roll kind of questions. And if you think about, say, just immune therapy, which we're going to focus on, for a long, long time, the whole strategy of immune therapy was trying to turn on the immune system, trying to speed it up, trying to wake it up. When it turned out that the high roll, innovative way of thinking about it was, it was just cutting the brakes, was really what we needed to do. The immune system wasn't broken. It just needed to be let loose. And so what we try to do with the investment in the Ruesch Center is, in fact, invest in those more high roll, high risk, high reward kinds of science that is traditionally not funded through standard funding mechanisms. And we think we've been pretty successful at that. We've had some fun. We've had the most fun maybe thing in my life was the video that we shot with Rachel Long, who's our nutritionist. We did a little cooking show. It was quite fun, but there's a video of that. But we've continued to produce information online and for both the medical and the patient community for what's going on in GI cancers. We continue to maintain a portfolio of videos for our patients and other providers in terms of the information that's out there. And we have a high number of views and watches, not quite to TikTok levels yet, but you wait, we are going to be there. Once we set all of these to music, you just watch out, okay? So you should hear Dr. Weinberg sing How to Get FOLFOX. It'll make you cry. It's just, it is a special moment for all of us, and we're looking forward to it. Another great source of pride is our GI Cancers Alliance. The second most effective advocacy group on the planet is the Leukemia and Lymphoma Society, one that is 150 diseases, but one bicycle ride. And the purpose of pulling together this alliance is that when, in fact, we can work together as a team around advocacy in the GI cancer space, we should work together while not losing our individual characteristics. So this has been an ongoing and effective effort for us out of the Ruesch Center. In conjunction with our friends from PER and Enclave, I just want to remind everybody, different than this meeting is the SOGO meeting, the School of GI Oncology, also hybrid, mixed, also downtown Washington. And this is much more of a nuts and bolts of where we are in the treatment of GI cancers today across all the spectrum. We already have 13 faculty from across the country lined up coming to Washington, co-chair that with Dr. Mike Chody, who used to be at Hopkins here, now at Arizona. Just some fun events. We just got off the golf course because that was a delayed event, where I'm proud to say that collaboratively we raised about $180,000 on a round of golf, a very nice round of golf. But because we want to reset it to its normal time, it just comes up in May. And then this summer, we have our sort of annual meeting with Hope Connections, a community-based advocacy program here that provides free services for cancer patients in terms of cancer support, emotional support, mind, body, nutrition, and the like. And I want to give a shout out to my co-author who's helping to raise the money for that restructuring of that building. It's a beautiful new building that they have purchased and will be opening live in the next few months. She'll correct me later when I get that wrong, but it's a really nice special place, and we partner tightly with Hope Connections. The agenda you have in front of you, and it's broken into really 3 main sections. The morning section is chaired by Dr. Ben Weinberg, and it's all about immunotherapy and how we're moving immunotherapy in and through GI cancers. And I will let him manage that, but you have the agenda in front of you. The second is chaired by Dr. Ruth He, and this is going to be more on signaling and signaling pathways. Some of the success we've seen, and both things that are ready for prime time clinically and things that are on the heels or that would be ready for prime time soon. So don't miss that session. And then in the afternoon, we switch gears to focus on racial inequalities in GI cancers. And so the entire session starts with our Schaefer Memorial Lecture by one of our new faculty, Dr. Derek Griffin, as you can see there. And then Marcus Noel will chair this afternoon and walk us through both some lectures and a panel discussion on the topic of racial inequalities. At 4:30, we start drinking. Okay, so and you can have to drink fast because at 5 o'clock, for those of you who want to attend, just down the hall here, Liza and I are being interviewed by Nora McInerney, who is a noted author and TikTok person, and TED Talk as well. She's been through her own battle with her husband, several events happening all at once, and she's a noted author and is coming to interview us about our book. And that's from 5 to 6 if you're interested in joining us just down the hall then. If you're not, please feel free to stay and drink until 6, or bring your drink in as you go. Tomorrow, all virtual, so don't come here. Stay in your jammies, go to your basement. And there are 2 main areas that we'll focus on. I'll be chairing a session looking at building your GI cancer dream team. And then who's chairing that second one? I should know. Maybe Ben, are you chairing it or are you just attending? So we're talking about integrative cancer care and sort of what we'll call alternative therapies. And this is primarily targeted to patients and caregivers tomorrow online. Everything is being filmed. Everything is either being streamed, or all of this is being streamed as well and recorded for later use if you wish. All right. And then also tomorrow morning, we have our annual carve out for neuroendocrine cancers, a group of cancers that frankly aren't that rare and have a place in our hearts and in our science. And so we have a special breakout for them tomorrow, again, all virtual. I cannot thank our sponsors enough. You see the list here, Natera and Exelixis, who have done so much to make this possible, but it's across the board, very, very positive support. And to that end, during breaks and the like, you can't escape without visiting them. So make sure you go and visit, say hello, and thank them for their support for this morning. Online, we are managing the chat. We have a iPad up here where if you put in questions, the moderators can see it. So feel free to tell us what you're thinking and share thoughts, and we will hopefully get to all the questions that people have. And of course, in here, I think we have some handhelds to pass around for those who here have questions. So we do want to make this interactive. For those who can and want, you can get CME. That's both medical and nursing CME for our event today. And we want you to do that. Follow us, please. We know that that is how a lot of us communicate and keep up with each other. So add us to your list on either Twitter or Facebook. And please, throughout the meeting, there are opportunities to fill out evaluations. So we encourage you to do that so that we learn how to do this better year after year. So with that, I think I am done with my introductory comments. And let me invite up my good friend and partner, Dr. Ben Weinberg, and he will get us started on our first scientific session, as I said, focused on immunotherapy. Thanks. Welcome, Dr. Weinberg.
Thank you, John, for that introduction. And I want to echo, it is very good to be out of the basement and in real life with real people. I think one of the signs that hopefully the pandemic has turned a corner is that, we're going to the cleaners and actually getting our suits clean from time to time versus taking them out of the closet once a year. So that's a happy change of pace. I want to also thank not only Oncology, but the Ruesch team, Craig, Kirsten, Marion, for helping, put all this together. these hybrid things are not easy. So hopefully it all goes smoothly. And then we're going to pipe in a couple of our speakers over the internet in a second. But just to briefly introduce this topic, I have no slides, but just to say, like Dr. Marshall said, just because there was a pandemic doesn't mean people stop getting cancer, especially these very common cancers that we're going to be talking about today. And we have seen folks delaying screening and presenting with more advanced disease. And one of the things that patients are always asking us, and we're always asking ourselves, is, well, what about immune therapy? We know what chemotherapy can and can't do. What can we do that's new, novel, less toxic for patients, more effective on their tumors, and potentially can even continue to work after you stop giving the drug, which is very different than the types of medicines we're used to giving. And aside from a sliver of patients with advanced colorectal cancer that we're going to talk about next, and some patients with hepatocellular cancer, maybe upper GI, these drugs unfortunately don't work in our cancers so far. And that's been very frustrating for us as we see our colleagues in the lung cancer world, the kidney cancer world, and the melanoma skin cancer world, where these drugs work like gangbusters. And so how do we adapt? How do we make them work in our cancers? And it's probably not going to be a one size fits all approach. Part of it is the different combinatorial approaches. Should we combining one immunotherapy with another immunotherapy, with radiation, with chemotherapy, with other targeted therapies? And then can we figure out who will actually benefit? Can we do a better job of biomarker analyses, dividing up patients into a pie chart where the slices get smaller, but more and more pieces of the pie where we know that these drugs can work? So that's what we're going to be talking about this morning. And I'll briefly, Dr. Overman, who I'll introduce in a second, is going to talk about MSI-H cancers. And then Dr. Redman is going to talk a little bit more about the non-MSI-H colon cancers. And then Dr. Azad is going to be talking about some other GI cancers and immune therapy. So quite a lineup of all-star, very bright, intelligent clinical researchers who are really making big strides in this field, and we're trying to follow in their footsteps and figure out where to go next. So without further ado, our first speaker is Dr. Michael Overman, who's going to be joining us online. There he is. Hi, Michael. Dr. Michael Overman is a professor of medicine at the University of Texas MD Anderson Cancer Center. He completed his undergraduate studies at Brown University and graduated from the Johns Hopkins School of Medicine. He then did his internal medicine residency at Harbor UCLA, where he served as the chief resident prior to his fellowship in hematology oncology at MD Anderson. Dr. Overman is a clinical trialist and translational researcher focused on pancreatic and intestinal cancers. He is the principal investigator on a number of clinical trials investigating immune checkpoint therapy in gastrointestinal malignancies. He has ongoing efforts to investigate the role of stromal modulation to enhance the activity of immune checkpoint therapy. Dr. Overman, take it away.
Thank you very much. Glad to be here virtually, and glad to see a good in-person contingent, which is fantastic. I'd like to thank Dr. Marshall and Dr. Weinberg and the Ruesch Center for the opportunity to talk to you today about a pretty exciting topic. Actually, this is one where I think Dr. Weinberg has mentioned we've had success, and so this goal of cure is one where we actually, I think, are obtaining in this tumor type. And I'll kind of talk through some of that data and why I really think we, at least for this subset, have really seen kind of a dramatic improvement in therapy for these patients. So my talk is going to be future directions for MSI-H deficient affair solid tumors. And so the agenda we're going to cover today is going to be really kind of background related to this subset, talk a little bit about kind of optimization of our current therapy, some predictive biomarkers, and then talk about some kind of future areas in kind of like a localized disease and then kind of the refractory space. And so to start with, I think, one, just to make the point that this subset is really unique. And so they are characterized by these frame shift mutations, these MSI events, and you can see clearly in that long top figure of a number of colorectal cancers, you see this dramatic rate of MSI events that you don't see in kind of the microsatellite stable cohort, which is primarily that kind of flat line there. And then in the bottom is also a figure that reflects the not just the quantity of these tumors having mutations, but the quality. And so that's kind of the pie chart there with that red sliver is the mutations from MSI patients. And then if you predict neoantigens, you see that red sliver is threefold bigger, right? And so that kind of relates to this unique phenomenon of insertion deletion mutations where you get frame shifts. And so you can lead to many amino acids being generated from one mutation. And so many different foreign amino acids, so many different neoantigens can be generated, not just changing one amino acid with kind of a normal type mutation. And so what this has led to is a tumor type that has both high mutation load and immunogenic mutations, and one where immune therapy works. And I'm going to kind of make the case that I think this is really a dramatic finding for our patients, and this is a cure in a number of patients. Now, the key is how do we increase that fraction? And I think that's really kind of where we're going. But I really, as we further follow these patients further and further, I think this is the phenomenon that we're seeing. And so to kind of make some of that statements, here would be two kind of data sets. So one is the original article from Science from Hopkins, Dung Lee, looking at pembrolizumab, and it was a 2-year duration of pembrolizumab, and they stopped at 2 years. And in those 18 patients that had stopped at 2 years at the time of reporting, none have recurred. And then there's another data set where we looked at our patients in a cohort in France for patients, metastatic patients we treated with PD-1 based therapy, and then looked at those that went to surgery. What do you find at the time of surgery? And so what you can see there is almost all of them were path complete response, right? So again, getting at the idea this therapy can be very definitive in regards to eradicating at least a pathology level, kind of the tumor that's there. And then kind of the other data set is this is long-term follow-up from a recent presentation at a meeting in regards to the refractory nivolumab ipilimumab cohort. And the idea there is really that 13-month follow-up snapshot and then the 51-month follow-up snapshot, right? And so what you do see is that flattening the curve has really continued. There's a little bit of dropping to some degree, but you can see there that the timelines for the 1 year and then for the 4 year, in regards to this flattening of the curve, and really at 4 years, we're seeing over 50% of people without progression, which for metastatic colorectal cancer patients is really kind of a dramatic finding. And one, I think that as we follow longer, we're going to say there's a fraction there that's clearly cured of their cancer. Now, the challenge, and this is the Keynote 177, so this is the classic randomized pembrolizumab versus chemotherapy in the front line. Clearly, the long-term separation of those curves dramatically favors pembrolizumab, but you do see some limitations, which is one, kind of that initial progression rate. So you see a crossover of the curves for both PFS and overall survival. And then clearly, you would like to make that kind of curve even higher than it is currently right now. Now, that initial progression rate is pretty consistent. If you look across the board, this is all a number of different PD-1s and deficient mismatch repair all have that progression disease rate that kind of relates to around about a third of patients. So there is this subset that's not benefiting. So how do we approach that? And I would kind of say, I think here's kind of two approaches one could consider at present. So one is let's do better immune therapy. So that might be combination immune therapy, and there is some data with frontline nivolumab ipilimumab that actually, not randomized in a small cohort, 45 patients, but does appear to have a higher response rate and lower progressive disease rate. And then the idea of what about combining with immune therapy and chemotherapy, which we've seen a lot of different tumor types. And so here is a good example from non-small cell lung cancer, immune therapy versus chemotherapy, crossing of the curves. You then combine that immune therapy with chemotherapy, and that curve crossing goes away, right? So kind of an example where that has played out and been successful. And so there are efforts in both these fronts, right? So this is kind of the current ongoing study, GI-004 SWOG 1610, looking at the idea of chemotherapy and immune therapy. And so in the frontline management of metastatic colorectal cancer that's deficient in mismatch repair. There was some recent data at ESMO. This is kind of the FOLFOXIRI, Bev plus minus atezo, a positive study, but a significant difference in regards to mismatch repair status. So the deficient mismatch repair, really dramatic benefit looking at kind of the addition of atezo, and so dramatic that one might say there is some synergistic benefit of the combination of chemotherapy with PD-1, and that's kind of been hypothesized related to VEGF and oxaliplatin benefits. And I think further reiterates the importance of the idea of combination as potentially a path forward. The other idea, again, as I said before, is the idea of improved immune therapy. And so So this is kind of the data set we have that would be the best to address that. And that's kind of the combination of avelumab, ipilimumab. And I think, if you look again at kind of the data follow-up, it looks very encouraging. And I would make the case that the PD rate for the front line is very similar to the refractory line, right? So you have 45 patients frontline, 119 refractory, both had a PD rate around 13%, 12%, very similar. Keynote 177 chemotherapy rate, 12%, right? So we're actually looking at an immune therapy combination that seems similar to the progression rate we see with chemotherapy, and clearly is lower than what we saw with that 30% of the pembrolizumab in the Keynote. And then I think the other point just to make on combination immune therapy is that, ipilimumab could be dosed different ways. I think we've improved over time with this. And so the frontline data set that I showed you was ipilimumab every 6 weeks. And that can be done. So here's the non-small cell lung cancer patient, 1,000 patients using nivolumab, ipilimumab, and you look at treatment-related deaths, 1%. So it does exist, but really similar chemo versus immune therapy. And so I think there is potentially improved tolerance of that combination. And I think I'd make the one case here that if you are going to do combination immune therapy, where should you do it? It would be in the case where you're looking at patients that have a high tumor mutation burden, right? So this is kind of where you actually extrapolate your toxicity risk kind of stays pretty stable across the board. But when you actually look at kind of your improved benefit with the combination, you see that get larger and larger as you have a higher tumor mutation burden. So this would be the tumor type where you'd really want to consider potentially going with combination-based therapy based on a large data set of patients looking at the difference between PD-1 and PD-1 CTLA-4 treatment. And then just to kind of add on this kind of optimization of immune therapy, this PD-1 CTLA-4 is that there was a BMS access program, non-randomized clearly, but with some hints that combination fared better than monotherapy, at least in this small kind of number of patients. There is a large randomized study that's ongoing, the Checkmate 8HW, which is actually looking at this question. So I think in time we're going to have an answer here, but that's not expected to provide a result for a number of years still coming, but looking at the question of, combo versus mono in deficient mesothelioma colorectal cancer. And then one other kind of interesting kind of novel approach that's out there is some work that we presented at this recent SITC, which is kind of an interesting approach, which is actually looking at a vaccine-based approach for MSI-H tumors. And I think one of the unique things of MSI-H tumors are a lot of different mutations, and there's a fair amount of shared mutations. So this is actually kind of predicated on some analysis where you can take 209 kind of frame shift mutations, and that will capture a mutation in 95% of MSI tumors, primarily gastric colorectal. And so with a shared vaccine, you can cover a very high range of tumor types because of the rate of mutations and kind of the similarity across tumor types. And so this is kind of a cassette that's put into 2 different viral vectors and provided, and very early results, 12 patients there looking encouraging. It's combined with pembrolizumab. And so I think a very early kind of status, but this idea of, vaccination, which I think is very interesting and would be another kind of way to think about optimizing, again, that immune therapy in our frontline setting. And so now I'm going to shift gears and talk a little bit about predictive biomarkers and what do we have in this space to kind of use that to potentially improve selection for who should we be treating. And I think the one point I want to make is that one of the best predictive biomarkers is deficient mismatch repair MSI-H, right? So I just kind of amazed whenever I go back to this figure, which patients benefit. It's the green ones, right? It's green versus red. It's pretty clear cut. You can't get much more clear cut than that when you're looking at, patient level data, I have to say. And so clearly a great biomarker. Now, we're going to look into it and say, could it be better? And I think there's always some caveats to it. And so there is some data out there. And clearly one of the suggestions across data sets is, who of the deficient mismatch repair MSI patients aren't responding. There's definitely a subset where we're miscalling them as deficient mismatch repair MSI-H, right? So could we do better? And this is some data from a French group in which central review, they changed kind of their call, and you can see here 8% and 10% of cases. So I think a little bit higher than we might expect here in the United States, but there's clearly a fraction where we are misidentifying them. And so it does bring up the question of should you, validate with another type of test, or, could you use other tests that provide other kind of supportive evidence of this? And so I think, the fundamental kind of idea here is many mutations. So I think, next generation sequencing provides us not only an MSI call, but also that validation of a high mutation load. And so that often provides that kind of second layer that's nice to have. So there is data out there, as one might expect, that the higher the mutation load, the more the improved or the better response. Very small data sets, a lot of different kind of thresholds for TMB in these data sets, right? So 10, 26, 40. And also I think the challenge is the non-responders are kind of a small subset and likely probably are enriched for non-deficient repair or miscalled proficient mismatch repair patients. There's also some data out there that not just your tumor mutation burden, but your type of mutation, which does make some sense. So here's some data that maybe it's more the level of frame shift mutations or insertion deletion mutations that are really driving that immune response, right? Those are the ones that really form these kind of qualitatively immunogenic mutations. And so maybe that's really the key kind of driver to predict kind of difference, not just kind of tumor mutation burden level. And then a final kind of predictor, which I think is really impressive and dramatic, that isn't in actually a colorectal cancer setting or a deficient mismatch repair setting, but this is just a large kind of cohort of patients treated with pembrolizumab as listed there, in which they looked at an early circulating tumor DNA readout as being used to predict benefit for progression-free survival, benefit for response rate, and in both cases, really dramatic in regards to the ability of an increase versus decrease in a circulating tumor DNA to kind of be a readout for benefit from therapy, and one that clearly I think would probably apply to deficient mismatch repair patients as well. And so to kind of switch gears now to talk about not just, optimizing what we're doing, but, moving into different settings and different kind of trial approaches. And so we're going to switch and talk a little about localized disease. All the data we've had so far has really been metastatic patients. There is a very large randomized adjuvant study that's ongoing. That's the Atomic study. But I think one of the more interesting areas is even earlier than adjuvant, the neoadjuvant space. And so here's kind of the first data set looking at neoadjuvant therapy. This was the niche trial data. So again, this was nivolumab, ipilimumab, 1 dose ipilimumab, 2 doses nivolumab, really almost 30 days prior to surgical resection. And you had 100% of patients having a response to therapy, which is really high. Now it's a small data set, 20 patients, but one does bring up the question, would you have better immune therapy response in tumor types that have not yet evaded the immune system and metastasize, right? To metastasize, you clearly have to evade the kind of immune surveillance that occurs within the tumor site. And so would you actually have more immune response in a localized setting? And I think the data seems to suggest that. Here's another data set that we recently presented at ESMO, where we did 35 patients. So this is deficient mismatch repair MSI high, any tumor type, mostly colorectal. You can see there 19 colon, 8 rectal, a few other different tumor types. And so 35 patients, 33 that actually we could have RECIST on. We had a 90-year-old patient that had a fall and broke their hip, and then that led to a death unrelated to therapy, and then another patient that actually kind of went on just directly to surgery. That I would say likely was progressing clinically. But of those 33, about half have gone to surgery, half have been going on therapy or kind of follow-up, and you can see kind of the distribution there. 1 patient did progress, so kind of two progressors there. 4 patients have finished 1 year of therapy. None of those have recurred. Some patients did stop early, and you can see there are the reasons for. All those patients were kind of benefiting at the decision that they wanted to stop, and that related a lot to kind of travel and time on study a little bit. And then we have 9 patients who are kind of ongoing therapy. So a study that's definitely early and kind of readout. but the readout we do have is impressive. And so here is 15 patients, pass CR rate is 69%. You can see listed there the different staging and then past staging following pembrolizumab. What's interesting to note, the two pancreas patients both didn't have path complete responses. There was an endometrial patient that didn't as well, that had a very nice kind of response down to T1A. So clearly, though, good kind of path responses that we're seeing, and in a number of cases, complete path responses, right? So I think this is kind of where this idea of, could this be a watchful waiting based approach? I think that's real. We talk about that a lot of rectal cancer when our path CR rates are much lower than, I would say, 69%. Some other efficacy endpoints from this study, and so you can see here response rate 75%, endoscopic evaluation, over 50% of people with complete response by a very strict kind of criteria, and then a number with kind of near complete. And then we also looked at an early ctDNA readout as well, so at 3 weeks. And what you can see here at 3 weeks is that we see kind of a good kind of predictor of what's going to happen to come with these patients, where the vast majority had a decrease in their ctDNA. Okay, so in the last section, I have 3 different kind of approaches in regards to kind of the deficient misfolded repair patients that progress on PD-1 therapy. And so how do we approach those patients? And clearly the idea here is you have success in the refractory, you can move this up earlier and potentially learn from that into earlier settings. And so one kind of really neat approach is actually borrowed from melanoma and some preclinical data, which I think is just really fascinating, which is this idea of microbiome modulation and its interplay with the immune response. And so this is, initially devised from mouse data, where you take patient microbiome and you put it into a mouse, and depending on that microbiome being from a responder patient or a non-responder patient, that determines whether the mouse tumor responds or doesn't respond. And then they did this in patients. So melanoma patients, PD-1 progressors, and all they did is change the microbiome. So microbiome from a melanoma responder patient was given to a non-responder, and that converted a fraction of patients in 2 different studies into responders. Really just pretty dramatic. You're just changing your microbiome, and that can kind of convert you into response status. And so we have a study ongoing that's actually looking at this. It just recently opened. We have kind of 2 patients on this study, but with the same kind of idea. So again, melanoma, high mutation load tumor type, deficient misfolded repair, a high mutation load tumor type. And so can you actually take a microbiome from a responder MSI patient, put it into a non-responder, and convert that patient to responding status? The other one is actually a recent article that actually had kind of a agnostic look with a mismatch repair deficient signature that they then applied to a large data set of drugs and cell lines. And one of the hits that came out was this drug, Pivinestat. And so that's actually a netylation inhibitor, which is in kind of the proteasome pathway. And so then there was some work done to try to look at this into why this drug was actually high on that kind of agnostic screening approach, and led to a really kind of interesting kind of logical process. And so the idea here is you have deficient misfolded repair tumors, lots of mutations. Those mutations gets transcribed and then translated into proteins, but you have proteins that have, incorrect amino acids. And so your folding is going to be altered. So you're going to have a lot of misfolded proteins. And so these tumors are characterized by a lot of misfolded proteins, actually, if you look at them. And so if you inhibit the process that clears those misfolding proteins, you have accumulation, and that becomes toxic to the cells, and that kills the cells. So kind of along the same line that we talk about in regard to generating kind of immunogenic proteins, you have these misfolding proteins at a high level, and so unique sensitivity that can be seen at kind of the protein-based level. And so then that plays out if you look at some cell lines and some model systems in regards to kind of using Pivinestat for, you see selectively activity in MSI, non-versus MSS tumors. And if you combine it with PD-1, you see kind of some synergistic activity. And so that also kind of predicated a study that we have at MD Anderson looking at Pivinestat and pembrolizumab and in deficient misfolded repair kind of refractory patients. And then I would say another kind of approach, and so this is actually by a speaker we're going to see very soon. So Dr. Azad has been leading the effort for a match arm. There was initially the Z1D arm, which was nivolumab in non-colorectal MSI-High tumors, tumor agnostic study that was published. And there's going to be a follow-up Z1M arm, which is looking at the idea of PD-1 MSI progressors, looking at the idea of PD-1 and LAG-3 combination. And so selecting off kind of LAG-3 expression as well, and predicated on just some as expected data that you're going to have high, immune markers in these tumor types. We know that. And so LAG-3 is high, PD-1 is high. And so, LAG-3 is one of those kind of markers that go up as you have exhaustion in your kind of T cell response. And clearly these tumor types have T cell recognition, and then that often gets exhausted with time. And so potentially this could be along the same lines as activity with PD-1 if you use combination. And so that's kind of ongoing. And Dr. Azad has been a champion in dealing with the match and the overall effort within that process, which has been really a lot of hard work on her behalf. And I think going to be a great study that is going to be open across the board, which is really great, kind of given the national approach of the match infrastructure. So to conclude here, I think at a high level, one is, we really should be testing all of our colorectal cancer patients. I hope they made the case that identifying this subset leads us to a therapy that has a dramatic potential difference in outcome. And that outcome is actually cure in a fraction of patients. And so as our goal set out by Dr. Marshall today, our goal should be that, and I agree with that. And this allows us to get to that for a subset of patients. And so really important we find these patients. Frontline therapy, I think we have monotherapy combination. I think really a toxicity efficacy discussion between the physician and patient. And then I do believe, neoadjuvant therapy is going to have a role. A lot of these tumors tend to be very locally advanced before they become metastatic. And so there is this issue of challenging surgical resection. I think neoadjuvant therapy is looking encouraging, and there's even this idea of watchful waiting. And then I think there are a number of ongoing efforts in this refractory PD-1 space, and I think activity there will help us understand how to approach even more optimization in earlier lines, I would say. And so a very area that I would encourage clinical trial enrollment to be done. So thank you very much.
Can you hear me? Yeah. Thank you, Dr. Overman, for an excellent, excellent talk. I have a lot of questions. We're actually going to save the questions to the end of the session. Please put them through the chat. I am getting them live. The next speaker is Dr. Jason Redman, who's joining us here in person. He's an assistant research physician in the Genitourinary Malignancies branch and the Laboratory of Tumor Immunology and Biology at the NCI at the NIH. He attended college at the University of Connecticut and medical school at New York Medical College. Between the third and fourth years of medical school, he was awarded a one-year fellowship from the Doris Duke Charitable Research Foundation in Cancer Immunotherapy, which he completed at the University of Iowa Carver College of Medicine. He went on to complete his residency in internal medicine at Georgetown and his oncology fellowship at the NCI. Dr. Redman is a physician treating cancer patients with combinations of immunotherapy, chemotherapy, and other therapies. He works on clinical trials for patients with prostate cancer, colon cancer, head and neck cancer, and other solid tumors. So please welcome Dr. Redman.
Ben? Great to be here back in person, and thank you for the opportunity to speak here. When giving a talk about microsatellite stable colorectal cancer and immunotherapy, it's a bit challenging because unlike microsatellite unstable disease, you've made some steps in the right direction, but I think we have a long way to go. So I'm going to share some background, and then I'll share some, I think, promising data with immune checkpoint inhibitors and targeted therapy. Then I'll share some data with chemotherapy plus IO agents. And then I'm going to share some combination approaches that we're working on with some of our preclinical folks at the NCI. So colorectal cancer is the third most common malignancy in the world, and it's increasing at an alarming rate in younger age groups. For metastatic disease, the median survival is about 2 years. And as Dr. Overman mentioned, hopefully we're getting much better outcomes for our microsatellite instability high patients. But for metastatic patients, the mainstay of treatment is 5-FU-based chemotherapy. And the objective response rates are good, but the median PFS is still less than a year. In the second line, response rates are 10, 20%, and we do have salvage regimens that are available, but they provide a marginal benefit at best. So talking about immunotherapy, the dominant strategy has been immune checkpoint inhibitors. And I think when you give a talk, you have to put up the generic and very oversimplified slide showing a T cell on the left there, which shows up and it's trying to kill a tumor cell. And these checkpoint molecules are regulatory molecules, and interactions can prevent the T cell from doing its job and killing the cancer cell. Monoclonal antibodies that block these interactions can then facilitate that activity. And on the right side, I put up a dendritic cell to remind us that these molecules are integral to other interactions, cell to cell. So if you have a dendritic cell that's presenting antigen to T cells, that T cell might not make as good or as avid T cells. And when you add checkpoint inhibitors to the equation, then they are better. So as Dr. Overman explained, there are several indications for checkpoint inhibitors in microsatellite instability high, but for mismatch repair proficient microsatellite stable patients don't work. And in thinking about the mission of the Ruesch Center, I wanted to put this slide up. I can remember when I was a resident and all this data was coming out in metastatic melanoma with checkpoint inhibitors. These dramatic responses you would see were really impressive. So this melanoma patient just riddled with metastases, and after receiving anti-CTLA-4, anti-PD-1, these dramatic responses. So, we all know that the majority of our patients won't enjoy responses like this, but I think we can be cautiously optimistic that by addressing the right regulatory mechanisms, we can hopefully make responses like this happen in more of our patients. So we know from the consensus immunoscore that the presence and position of CD3 and CD8 T cells is predictive of response in stage 1, 2, and 3 colon cancer. It's also predictive of outcomes in stage 4. And this is presumably because we have some T cells there that are engaging in anti-tumor activity of some sort. Albeit it's not enough to eradicate the tumor, but they're there. And I think the question is, how can we help them do their job? So the first strategy I'll talk about is multi-targeted TKIs in combination with checkpoint inhibitors. Many signaling pathways can overall have an immune inhibitory effect on the immune system. And when you block things like VEGF, you get increased tumor infiltrate and removal of some of the regulatory mechanisms. And we have regorafenib, which is approved as monotherapy for colon cancer. And there's actually preclinical models that show synergy when you combine PD-1 with regorafenib. And there's lenvatinib, another multi-targeted TKI, targets VEGF, among other things. And this also is shown to have synergy in preclinical models. And before I talk about combination strategies with these two, there was another trial which combined atezolizumab with cobimetinib. So MAP kinase signaling also can create immunosuppressive forces within the tumor microenvironment, and there's a wealth of preclinical data suggesting that blocking that can create an immune permissive effect. Cobimetinib is a MEK1 and 2 inhibitor, and this trial was multi-center open label. That's a typo. It was a randomized. It's a randomized phase 2. And patients received atezo plus Cobi, atezo alone, or regorafenib alone. Primary endpoint was overall survival. So despite this strong preclinical rationale, it ended up being a negative study. You can see that the survival curves overlap. Moving on, Rego-Nivo, regorafenib plus nivolumab. This was pretty exciting data that came out a couple of years ago. They treated gastric and colorectal cancer patients in a phase 1b study. That was conducted in Japan. All patients had at least 2 lines of prior therapy, and they received regorafenib at doses 80 to 160 milligrams in combination with nivolumab. So 25 of these patients were colorectal cancer. 1 patient was microsatellite instability high, and the response rate reported was 33% in the microsatellite instability high group. So pretty exciting data. And then earlier this year at GI ASCO, the Rego-Nivo study in a North American population was reported. So similar population, at least 2 lines of treatment in most patients. They received escalating doses of regorafenib starting at 80 milligrams. Fortunately, the response rate was only 7% in the 70 patients that they evaluated. Looking at a subgroup, patients who did not have liver metastases, mostly nodal metastases, had a response rate of 21.7%. So these are small sample sizes, and I think it's unclear exactly what's going on here. The most obvious thing is that there is, depending on the ethnic population, there seems to be a discrepancy, but hopefully with larger data sets, we can gain more insight. And next, I'll talk about lenvatinib with pembrolizumab. This was presented at ASCO this year. It was a non-randomized single-arm phase 2 study. It excluded all microsatellite instability high patients. They all had 2 lines of therapy, and patients received lenvatinib 20 milligrams plus pembro. There were 50% grade 3 to 5 treatment-related adverse events. Unfortunately, one patient with an intestinal perforation, which is known to be a potential side effect with lenvatinib. In terms of response rate, there were 32 evaluable patients, and they reported 22%. And they're expanding to 100 patients, so it'll be interesting to see if this is replicated in a larger sample size. Now switching gears to combining immunotherapy with chemotherapy. So there's a wealth of data out there suggesting that chemotherapy provides several immune-enhancing effects. So this includes oxaliplatin, which causes more of an immunogenic cell death. So you have a cancer cell that's dying after exposure to chemotherapy, and through expression of calreticulin, it becomes more interesting to an antigen-presenting cell and can theoretically generate an immune response. 5-FU also has some immunomodulatory properties, increasing co-stimulatory markers, and oxaliplatin does that as well. And this is a very limited overview. There's a wealth of preclinical papers out there that have shown synergy here. So the Atezo tribe phase 3 trial, this is a typo here, it's not a phase 2, randomized patients to FOLFOXIRI plus bevacizumab or that regimen plus atezolizumab in the first-line setting. And they then went on to receive maintenance therapy with or without atezolizumab. They did allow some microsatellite instability high patients, primary endpoint PFS. And this was just reported at ESMO this fall. There was a similar safety profile with both regimens. And at a median follow-up time of 19.9 months, there were 159 PFS events. So the study technically met its primary endpoint. It was 13.1 versus 11.5 months. But as I mentioned, they did enroll some microsatellite unstable patients. And when you analyzed it for only the microsatellite stable group, there was a trend towards better PFS, but it was not statistically similar response rates for each arm. So doesn't appear to provide a very significant benefit short term, but it will be interesting to see if the long-term survival is reported here. They have a nice big sample size, and it might be possible to tease out a difference there. Next, we did a trial in collaboration with Georgetown and dual site enrolled patients at NCI in Georgetown. This was in the first line setting, and what we did was we randomized patients to FOLFOX plus bevacizumab or FOLFOX plus bevacizumab plus an anti-PD-L1, avelumab, and a CEA-targeted vaccine. Patients then went on to get maintenance therapy, and we did allow crossover if patients randomized to standard of care had progression. So unfortunately, this trial was slow to accrue, and we did close it early after we accrued 10 patients per arm, but we did learn a few things. So I'll just show here that the response rate was similar between arms. We did have 4 patients that crossed over after receiving standard of care, and unfortunately, none of them ended up going on to have objective responses. And then when we did the PFS analysis, the curves do overlap. So consistent with what they saw in the larger study. The exciting thing we did learn was from correlative analyses. So the vaccine targeted CEA, and when we looked at the immune responses, the peripheral blood to CEA and also to cascade antigens, MUC1 and brachyury, we saw that patients who received the regimen had a higher incidence of multifunctional T cells specific for brachyury or MUC1 and brachyury. So this sort of suggests that perhaps with the right immune oncology agents, we can perhaps utilize these cells in a combination regimen. And now I'm going to switch to something that's a little more positive. This is a case anecdote, a patient we treated at the NCI, which is informing some of the work that we're doing moving forward. So it was a 42-year-old patient with NRAS mutant BRAF wild type microsatellite stable rectal cancer. He was diagnosed 2016, he had neoadjuvant therapy, adjuvant therapy, and unfortunately recurred a couple of lung metastases, which he had irradiated. He then had some bone mets, which he also had irradiated. And then he came to us and enrolled on a phase 1 trial. This was a phase 1 trial, also an adenoviral vaccine targeting CEA, MUC1, and Biliary. And just a little bit about these vaccine targets. I think GI oncologists were all familiar with CEA, which is overexpressed on colon cancer. MUC1 also overexpressed and is of particular interest because the C terminus is an agonist and can induce plasticity. Biliary is a transcription factor that's very key to invasion and metastases, a really bad actor in lots of cancers, and also is commonly expressed in colon cancer. So this patient enrolled on our trial, and a little bit about the trial. So these regimens are favorable because they have very mild side effect profile, just flu-like illness, injection site reactions. And what we published was no objective responses, unfortunately, but all patients did develop antigen-specific T-cell responses to the agents. And this patient experienced progressive disease on the trial, and then he enrolled on a second phase 1 trial with us, rather. So I'll tell you a little bit about the drugs he received. He received bintrafusp alfa, which is an anti-PD-L1 antibody. It's modified to have the TGF-beta receptor on the FC region, so it locally sequesters transforming growth factor beta. The other agent is N803, which is an IL-15 analog. And this expands T cells and NK cells and increases activation state. So this patient, I have his CEA curve plotted here. And when he enrolled on the vaccine trial, his CEA continued to rise and he experienced progressive disease. And then when he started on our trial, we had a dramatic drop in his CEA that was durable. And associated with that, I have his scans here. So you can see when he started treatment, he had this big right upper lobe mass in his lungs. He also had a smaller nodule in the left upper lobe as well. And after 2 months on treatment, you can see that the right mass just almost completely went away and the other one cavitated and hollowed out. So we were excited about this, and he actually continued on treatment for 10 months. He had a confirmed response that was durable for 9+ months. Unfortunately, he had regrowth in the left upper lobe nodule, had radiation. He then, a few months later, had a large brain metastasis that we think was probably present for some time, and he underwent resection and radiotherapy. But remarkably, now about 2 years after his brain met resection, he has no evidence. So this is about 3 years after starting on trial. So this is just one patient, but trying to think about what happened here, how can we use it to make better immunotherapy strategies for our patients? He received a tumor-targeted vaccine, and we know from the phase 1 trial that these patients develop antigen cell responses, but he experienced progressive. Then in the context of checkpoint inhibition with IL-15, he went on to have this partial response. And even though he required ablative therapy, it was successful, and he hasn't had recurrent disease for almost 2 years now. So in hypothesizing what's going on here, putting together all the pieces, what's the biology here? So we give a tumor-targeted vaccine that creates antigen-specific T cells to CEA, MUC1, and Biliary. We add in interleukin-15, which activates and expands those cells. And we have to remember, too, there may be some endogenous T cells there. We know from the immunoscore that many patients, there is an infiltrate that's there trying to have some anti-tumor activity. So those are activated and expanded as well. And then N803 also activates and expands endogenous NK cells. So then when you think about what's happening at the tumor in this context, we've got effector T cells, vaccine-derived or endogenous. They're enabled by PD-L1 blockade, TGF-beta sequestration. Then you also have natural killer cells that are facilitating at some point. And it's hard to say what exactly is happening here in a patient where you can't do biopsies in real time, but when you see dramatic results like this, I think that it's not a bad problem to say, well, there might be a few mechanisms of action at play here, where we're trying to cover as many bases as we can. And then looking at preclinical data, our colleagues at the NCI have tested this in a few iterations. So in the MC38 colon cancer model, they've combined vaccine with anti-PD-L1, with IL-15, and also with another cytokine. It's a tumor-targeted cytokine called NHS-IL12. And I just have a picture of the molecule. It's just a monoclonal antibody that targets necrotic DNA and has interleukin-12 attached to the FC region. So in the mouse models, you can see that only when you combine all 4 agents, you get cures in the majority of the mice. So this sort of, it lacks in not providing a mechanism, but it does sort of support what we saw in this patient and is what we've used to inform a trial that we have open now. It's called quadruple immunotherapy, colon cancer, QUIC as we call it. So in the first arm, we combined the 3 agents that I just discussed, a checkpoint with vaccine, with IL-15, and in case that's not enough or not enough in all patients, we've included another arm that has those 3 agents and adds in tumor-targeted IL-12 as well. So this is colorectal cancer, small bowel cancer, measurable disease by RECIST is required, at least 2 lines of therapy, and objective response rate is the primary endpoint. The trial has an amendment pending relative to bintrafusp alpha, but we hope to have some exciting results to share this trial soon. And then lastly, one other approach at the NCI based on some work done by my colleagues there. So they've demonstrated in preclinical models that anti-PD-L1 plus this tumor-targeted NHS-IL-12 does work in at least in mouse models. And we know that we've had good results in mice for years and years. So what's the next thing that we can add in there? And one of our colleagues, Sofia Gamero, added in an HDAC inhibitor, so histone deacetylase inhibitor with NHS-IL-12. And that 2 different tumor models that use cures in several mice. And I unfortunately can't share data with the 3-drug combo, but we do have some data which supports this in clinical trial, which is the last one that I'll share with you. So we'll combine the HDAC inhibitor with anti-PD-L1 with NHS-IL-12. And this is going to have a microsatellite stable colorectal cancer cohort. Again, this is also pending amendment in relation to bintrafusp alpha, but we are hopeful that we'll be able to share some exciting results soon. So in summary, there's some interesting activity seen with regorafenib plus nivolumab. It appears that this might have something to do with the ethnic population treated, and also patients who do not have liver mets seem more likely to respond. There's also a trial with regorafenib plus pembrolizumab, which is ongoing, which may provide more insight into the efficacy of this combination. Lenvatinib plus pembrolizumab also showed some preliminary efficacy, and we're excited to see the results once the trial expands. I think combining immune checkpoint inhibitors with chemotherapy doesn't appear to improve short-term outcomes, response rate, and PFS, but the effect on overall survival is unknown, and also these regimens in subsequent line therapy is an area of interest as well. And we have also shown that when we combine chemo with these immunotherapy regimens, we create antigen-specific T cells, which may be there and useful in combination with other treatments. And next, we have some preclinical and anecdotal clinical evidence of checkpoint, vaccine, plus cytokine being effective. I'm not sure what happened there, but the last bullet I was going to share was, I think with the growing pipeline of immune oncology agents, I really think in a couple years, as we learn how to better address the immunosuppressive elements within tumor, that hopefully we'll have some much more exciting data to share with you all. Thank you.
Thank you, Dr. Redman, for presenting a lot of interesting data in a very short period of time. We're actually a couple minutes ahead of schedule, and wanted to highlight, one of the benefits of the work at the NCI is their ability to, play with lots of different companies and be able to put together these types of trials where you're combining not like 1 or 2 drugs, but like 3 or 4 of different corporate entities, which is very impressive and very neat. I don't know if Dr. Azad is on the line yet. We are, there she is.
I am.
A couple minutes ahead of time. So this will be good. We'll have a couple extra minutes for questions. So Dr. Nilofer Azad is a professor of oncology at Johns Hopkins University School of Medicine. She directs the Developmental Therapeutics Clinical Trials Program for the Johns Hopkins Sidney Kimmel Cancer Center. Dr. Azad trained at Baylor College of Medicine in Houston, Texas, and the National Cancer Institute in Bethesda, Maryland. Over the past 15 years, she has been on the faculty at Johns Hopkins, where she cares for and directs research in GI cancers. Dr. Azad's research focuses on early phase drug development and the intersection of moving exciting laboratory findings into patients for new treatment options. Without further ado, Dr. Azad.
Well, good morning, and thank you very much for that kind introduction. And I want to thank you and Dr. Marshall and all the organizers for inviting me here today. I have given a talk on this topic many times over the last few years, and I don't know that I've ever been as excited to give that talk as I am today, and I think you're going to see why. And that's because we finally have emerging data that immunomodulation and IO therapy does work in biliary tract cancers. And so I think we're about to open up a brand new arena for our patients. One that many of us have believed in for a long time, but now we're going to have data that allows this to be standard of care for our patients. So these are my disclosures, both my consultancies as well as the research funding that I get for clinical trials. And what I'm hoping to do today is to briefly review some of the epidemiology data that we have for biliary tract cancers, because though it is a rare cancer, it's growing, we're seeing more of it. And then discuss some of the data that exists from previously reported trials that haven't been as successful of IO therapy in our tumor type, but then talk about rational development strategies and highlight some of the trials that are being done both in our institution and in the area, so that we can talk about how we might best move these therapies forward for our patients. So first, if we look at what we're seeing with biliary tract cancers, for many years, this has been considered a rare tumor. It qualifies as a rare tumor at the NCI. 10 years ago, the incidence was considered to be about 10,000 cases. That incidence is growing, especially with intrahepatic cholangiocarcinoma, where the case load is growing from 0.1 to 0.6 per 100,000. Many of these increased cases are likely just better classification of cancer of unknown primary, but we are seeing an intrahepatic cholangiocarcinoma growth overall as well. And there are endemic regions predominantly in Asia where we see even higher incidences, 40 times higher in Thailand and China, as well as gallbladder cancer, which is endemic in North India and Pakistan, as well as Japan. We know that there are some risk factors for biliary tract cancer, though, like most GI cancers, the vast majority of patients that develop cholangiocarcinoma are going to develop it without any known risk factor. But chronic hepatitis or cirrhosis not only predisposes people's risk for HCC, it also predisposes to cholangiocarcinoma as well. And that comes from many causes. Primary sclerosing cholangitis is a growing known cause of especially intrahepatic cholangiocarcinoma, but we have other known causes as well. And then in terms of genetic syndromes, Lynch syndrome and BAC1, which we kind of consider general tumor predisposition syndromes, are also associated with an increased risk for biliary tract cancer. Now, over the last 20 or 30 years, we've generally considered our classification of BTC more by anatomy than by molecular changes, though that is now growing since we have a better understanding of molecular and biological differences between cholangiocarcinoma subtypes. But predominantly, if you look at how trials were stratified previously or how cholangios were classified, it was based on anatomy. So intrahepatic cholangiocarcinomas that arise out of the intrahepatic bile ducts, extrahepatic cholangiocarcinomas that arise from extrahepatic ducts and were really treated with Whipple surgeries if they were found in curative intent. And then Klatskin tumors or hilar cholangiocarcinomas, much more difficult to intervene on surgically. And here is a place where transplant has been considered in terms of surgical outcomes. Gallbladder cancer is also biliary epithelium, and so it is often under the subgroup of cholangiocarcinoma, but it is its own unique entity as well. But what we're learning is that not just anatomy, but anatomy may also define molecular differences that are very meaningful because now we have actionable mutations among these differences. So intrahepatic cholangiocarcinoma, almost 50% of intrahepatic cholangiocarcinoma has something actionable in terms of a drug that can target that given molecular abnormality. IDH is really driving that in terms of prevalence, with 20 to 25% of patients having IDH1 mutations and intrahepatic cholangio. But FGFR fusions are very important to highlight as well. This is 10 to 15% of intrahepatic cholangiocarcinomas. I want to again emphasize this is fusions, not mutations. We'll often see FGFR2 mutations, but that is not where FGFR inhibitors work. But we now have multiple drugs that are approved for patients with FGFR2 fusions. BRAF, MSI, HER2, there are papers that have come out, many led by our MD Anderson colleagues, that have shown activity in BRAF and HER2 positive disease. And this is even more prevalent in extrahepatic and gallbladder cancers. But salient to our talk today, what's important is that there are actually immune subtypes as well that might really help guide therapy and drug development when it comes to immunotherapy as well. There was a very key paper published in Cancer Discovery 3 or 4 years ago that classified cholangiocarcinoma into 4 different subtypes. And those were these different clusters, cluster 1 through cluster 4. And what you can see here on the right top figure is that the mutation load was substantially different among the different clusters. So cluster 1 had a much higher mutation load, and this was not all MSI at all. So this is a subgroup of patients that had high tumor mutation burden. And then clusters 2 and clusters 3 and 4, where that was less elevated in terms of the mutation load. This also showed correlation with PD-1 and PD-L1 staining. Because this is a rare tumor, there is a lot of discrepancy among different groups that have published on small subsets of cholangio patients in terms of what kind of PD-1 and PD-L1 positivity we see. So there's some series that have shown 15 to 20%, and some series that have shown up to 80% of these patients are PD-L1 positive. Another really important paper published just last year used a different classification scheme to try to classify just immune subtypes, and they came up with 4 different immune subtypes. And this was based on RNA expression, looking at DNA methylation, and looking at tumor microenvironment cell populations, and using that to drive the 4 different classifications. You can see here on the right, this is staining for different immune cells. And this immune subcluster 2 has high staining for CD4, CD8 cells, as opposed to this subcluster 1, which has almost no staining, and the 3rd and 4th subclusters that have different cell populations that are higher versus lower. This allowed the group to classify patients into 4 different subgroups, with that first subgroup being the immune desert, the second subgroup being an immune rich, which might be a particularly exciting group to target immunotherapy approaches for, and then a myeloid subgroup where using anti-myeloid therapies may be useful, and then a mesenchymal group as well. So this opens up the question of the challenge of the tumor microenvironment in cholangiocarcinoma. And what I just showed you is that there's significant heterogeneity among the different cholangiocarcinoma subgroups in terms of which patients might have this immune desert, which just comes from this beautiful paper from 2017, where patients can be classified into 3 different subgroups: the inflamed subgroup, the 2 immune excluded, and the immune desert. And in cholangiocarcinoma, we have patients that will classify in any number of these subgroups. So while we know that there are subgroups based on clinical characteristics that might respond more to immunotherapy because they have underlying inflammation, and we know that this goes with chemotherapy and immunotherapy response in other tumor types. We have subgroups that have high tumor mutation burden, but that's a minority. We really are going to need to understand who these patients are in order to best tailor immunotherapy approaches. And this might be why there's been, I would say, modest benefit, if any, from single agent PD-1 therapy given alone. And so this is the most recent number of clinical trials that have been done with single agent, or here we see PD-1 plus PD-L1 plus CTLA-4 inhibition. And if you look at the response rates, they really range from 2 to 3% to 20% in that paper from Dr. Kim's group out of Moffitt. And we're going to look at that group of patients as well as this pembrolizumab Keynote 158 study a little bit more closely because they're the largest studies and they do have discrepant findings in terms of response rate that was seen. So the largest trial that was done is the Keynote 158 study reported 2 years ago with 104 patients that were treated with pembrolizumab. Patients were PD-L1 positive, CPS score of greater than 1, and they had to have at least 1 prior line of therapy. The confirmed response rate was 5.8%, 6.6% if you were PD-L1 positive at that 1% threshold, and 2.9% if you were PD-L1 negative, and a median PFS of 2 months. So this showed that there was a small subgroup of patients that benefited, but really wasn't enough to move this forward as a registration strategy. If you compare this to Dr. Kim's work that was published last year in JAMA Oncology, they reported a median PFS of 3.7 months. And if they stratified by PD-L1 status, there did seem to be a difference in how much patients benefited. Now, they had a 22% response rate when the investigators reviewed the patients, but when they did central review, that number dropped to 11%. So people will make arguments both ways that when an investigator reviews scans that there is a bias, and so the central review is clearly more objective, but an investigator might be able to understand nuances of benefit in terms of investigator reviewed. So that response rate though, central review 11%, that's not as discrepant as the 6% that was seen, but if we go with the 22%, that's a big difference. And so if you look at the idea of potentially combining immunotherapy in the front line, maybe that's the best strategy to use this. The most compelling study that's been reported last year is looking at the addition of durva, PD-L1 inhibitor with gemcitabine and cisplatin, plus or minus tremi, which is a CTLA-4 inhibitor. And this is a little bit of a complicated study. There were 3 different groups. One group got all groups got gemcitabine cisplatin, all groups got durvalumab, but one group also got tremi. And of the 2 groups that two groups got durva and tremi, and of the other group that got durva and tremi, they called this the biomarker cohort. And if you look at what they did here on the upper left-hand corner, that first cycle of therapy, patients did not get immune checkpoint inhibitor therapy. They just got 1 cycle of gemcitabine and cisplatin, and they did tumor biopsies before and after just chemotherapy. But if you look over here on the right, the response rates here were quite compelling. The baseline response rate of the biomarker cohort was 50%. And if the patients started with durva or durva and tremi, that response rate went up to 73%. So compared to the 25% response rate that you would expect with gemcitabine and cisplatin alone, this is a meaningful difference, although this was an Asian cohort of patients. If you then look at the disease control rate, which is the second row to the bottom on the right, you see across all of these, the patient's disease control rate was close to 100%, 96.7% up to 100%. So this is very compelling data in terms of what might benefit from the addition of IO therapy to frontline therapy. Now, interestingly, the difference between adding durva or durva and tremi didn't seem to make a difference. So you got that benefit in response rate as soon as the PD-L1 inhibitor was added, and the addition of the CTLA-4 inhibitor did not seem to add much. The group did look at biomarkers, especially in that biomarker cohort. And again, I remind you that these are after patients had received a cycle of chemotherapy, but patients that had PD-L1 high at a 1% cutoff. Here you see on the upper left that there is a PFS difference that grows in magnitude when that cutoff gets to 25%, but there was not an overall survival benefit that was seen. If you look at the fine print here, though, the median overall survival in the 25% cutoff was 17 months versus 12.1 months. This didn't meet statistical significance, but this wasn't a large study, so it would be hard to meet OS statistical significance, but definitely food for thought. And here on the right, looking at cfDNA, they did see that variant allele frequency went down in patients that were responders, that's the R, compared to patients that were non-responders, where there was no meaningful change in cfDNA allele frequency. So what does this mean? First, we saw a higher response rate and PFS than we would expect in the control arm, but even the control arm did get durva-tremi plus gemcitabine and cisplatin. We didn't know the MSI status of these patients. The intrahepatic component was also not known, and there have been other studies where intrahepatic cholangiocarcinoma appears to do better with IO therapy. Anti-CTLA-4 didn't seem to add much, and so the biomarkers also create a potential interesting area for development. So this has resulted in the TOPAZ-1 study, which was a phase 3 study that has fully enrolled, combining gemcitabine cisplatin with durva versus gemcitabine cisplatin alone. Again, the data didn't suggest they needed the CTLA-4 inhibitor, and clearly that adds toxicity. And we're going to come back to TOPAZ-1 in a second. So the other agent that had been very exciting and that had been combined with first-line therapy was this agent that Dr. Redman just discussed, which is bintrafusp M7824, which is a TGF-beta PD-L1 bispecific antibody. This study was interesting. It was a small study of 30 patients, but showed a response rate of greater than 20%. And in intrahepatic cholangiocarcinoma, the overall response rate was 40%, with the median duration of response not reached. And here you can see the waterfall plot on the right. And so as we were moving forward as a community over the last couple of years, these were the two major trials that were moving forward in the first line combining with immunotherapy. And I will admit that when I was choosing between these two studies of which trial I was going to open, I decided to choose the trial of the bispecific antibody. I thought the data was more compelling. I thought that the idea of combination therapy in that setting was going to be more interesting. And I turned down the idea of participating in TOPAZ-1. And this is just a mea culpa from me, because we this year have had two reports. One, that this study was not positive. It did not meet its endpoint at interim analysis. And so this study was halted in terms of the phase 3 trial, adding it to first line therapy. The second line single agent study also reported in a press release that they were not moving forward with that development strategy with a response rate of approximately 10%. And so I bet on this one, and that bet didn't work out. But luckily, TOPAZ-1 looks like it did work out. So we just last month, you can see at the very bottom, October 25th, 2021, so hot off the presses, a press release from AstraZeneca saying that they were halting this trial because it was recommended to halt the trial because of significantly improved overall survival. These results are going to be discussed at ASCO GI in January. But considering that this was an interim analysis that halted the trial, I think it's very likely that within the next year, we're going to see an approval of this combination. Of course, we need to wait and see what the data shows. But I think this is extraordinarily exciting for patients with biliary tract cancer and for those of us that research in this space, because after years of trying to beg companies to work in this space, with them being worried that cholangiocarcinoma was a cold tumor, I think this is really going to jumpstart what our possibilities are as we move forward. But in the interim, what rational strategies have been working or have been working to test as we move forward? And I'd like to highlight a few studies that I find particularly exciting, although there are multiple different rational strategies that are being tested in this arena. And the first is the idea of radiation therapy being combined with immune checkpoint inhibitor therapy. And so, of course, there's preclinical data and clinical data that suggests that when patients receive radiation, it increases the diversity of the TCL repertoire, likely because of DNA damage that occurs. Anti-CTLA therapy inhibits regulatory T cells, and so combining them with PD-1 therapy might really help after radiation to activate the immune system and result in abscopal effects that can end up resulting in responses and benefit for patients. And based on this rationale, Ted Hong and Aparna Parikh at MGH have embarked on a series of clinical trials looking at dual checkpoint blockade with radiation. Now, they've reported in colon cancer, they've reported in pancreatic cancer, and this is the study in biliary tract cancers where patients were given tremi and durva upfront for 4 weeks, and then they were given relatively low dose radiation to a single lesion, and then that was followed up with them getting more durva tremi and then being on maintenance therapy with durvalumab. Their data has not been fully reported yet, but they did show out of 15 patients that they had a response rate of about 10 to 15%. Their challenge on that study was that they gave a month of therapy and then they lost many patients before they were even able to go onto radiation. So they've actually modified their trial and they're now moving forward with a clinical trial where patients get concurrent immunotherapy with radiation, so they don't have that dropout after that first month of therapy. I also wanted to highlight Dr. He's study that's being done here at Georgetown. This is a study also looking to leverage DNA damage as a possible mechanism to activate the immune system and then give immunotherapy. We know that actually, if you look at GI cancers, cholangiocarcinoma has got the highest rate of having defects in DNA damage repair. In fact, homologous recombination defects are found in about a quarter of patients. And so this is quite common for this group of patients. And the idea is that if we jump in with a PARP inhibitor, as we know, PARP inhibitors can have significant activity in BRCA-positive cancers because of that HR defect. Could we use that to increase the neoantigen exposure and bring in the PD-1 inhibitor as well? So this is the study, the way that it's designed. I believe 12 patients have been enrolled in this study so far, and they continue to accrue. Patients are given olaparib as well as pembrolizumab, and they do have biopsies that are incorporated into this trial that I think are really, really important, because this is how we're going to learn from these kinds of studies, whether we're really doing what we think that we're doing when we look at the tumor level, and then we can build on these strategies. And I'm going to show you an example of that in a second. And that's our trial of MEK inhibition, where the biopsies that we did and the preclinical work that we did both before and after this study has really helped us understand what we could do potentially with MEK inhibition for its immunomodulatory effect. So Dr. Redman and Dr. Overman briefly discussed the MBLAZE study where MEK inhibitors were given with PD-1 or PD-L1 therapy, and those trials were negative in colon cancer. So this is the data that allowed people to be enthusiastic about the idea of using MEK inhibition as an immunomodulatory agent. One, that you could see increased CD8 cell infiltration in preclinical models, increased MHC class expression, and when you combine these in tumor models, that you were able to see here in the lower figure, you see the red line is representing the MEK plus PD-1 therapy, where you're really not getting any activity from MEK or PD-1 alone, but when you put these two together, you have significant anti-tumor effect. So MBRAVE went forward in colorectal cancer at the same time that we were opening a clinical trial looking at the same combination in cholangiocarcinoma. In our study, we gave MEK at the exact same regimen, atezolizumab plus cobimetinib in combination with, compared to PD-L1 alone. And our primary endpoint was progression-free survival. And here you can see on the right, we actually met our primary endpoint. So this was a positive study. It had a statistically significant p-value. But if you look here on the right, you look at the tails of these curves. We didn't see an overall survival benefit, though it was a small study. So this did not move the goalposts enough for us to be excited to try to move this into a phase 3 setting. So we went back to the laboratory to try to figure out what might have happened. First, we looked at the tumor biopsies from these patients, and what we were able to show is there was an increase in cells, but that didn't end up correlating with benefit for these patients. And so Mark Yarshwin, working with Lauren Dennison, who was a graduate student in the lab, tried to pull out what was going on. And was this because MEK was having an impact not just on the tumor, but also on cells in the tumor microenvironment, and that those effects might be contrary to what we want when it comes to what effect they were having on immune cells. So what Lauren did first was she did a MEK knockout, and she knocked MEK out of these cells and planted them into mice. And when you knock out MEK and you combine these with therapy, you see here that the mice that lived the longest were the mice that had an intact immune system where MEK was knocked out. On the other hand, if the mouse did not have an intact immune system in these RAG knockout mice, MEK didn't do anything. So this suggested that MEK inhibition only worked if you had an intact immune system. She then looked at immune competent mice and found that there was a side effect of giving systemic MEK inhibition, where if systemic MEK inhibition was given, you had a decrease in T cell function, as shown here by interferon gamma and granzyme B, a decrease in T cell function if it was given systemically. And this makes sense because if you look at TCR signaling, MEK is actually a key downstream regulator of TCR signaling. And so what seemed likely was that you were inhibiting T cell signaling while at the same time getting a benefit that you wanted when you looked at the tumor. And you could reverse that by adding a T cell agonist. And that's what you see here on the right. The addition of 4-1BB, a T cell agonist, reversed that impact. And now you see that these animals did well. So we hypothesized that we could combine PD-L1 MEK inhibition with an immune cell agonist, and this would improve clinical outcomes with patients with biliary tract cancer. So maybe we would see benefit where before we had seen just a small improvement in progression-free survival. And so working together with CTEP, we have now activated just this last 2 weeks, this combination study of atezolizumab, varli, with or without cobimetinib, and varli as a CD27 agonist in patients with unresectable biliary tract cancer. The way that this trial is designed, patients can go on study after second or third line therapy. Patients are randomized to getting the triplet versus the doublet. The doublet will be PD-1 plus the CD27 agonist, and the triplet adds in the MEK inhibitor as well. And we have an overall response rate endpoint. So 64 patients will be enrolled in this study, 32 per arm. And we're looking for, in a two-stage, for patients' response rate. If both arms meet this response rate criteria, then we'll use PFS to break the tie. The eligibility for this study is patients can have either cholangio or gallbladder cancer. As I mentioned, this is second or third line therapy. And then all the rest are kind of standard eligibility criteria as you might expect. Right now, we have an exclusion for prior IO therapy. We're going to amend the trial, and we're going to allow for prior IO therapy because we believe that after the January TOPAZ-1 data is released, that patients are going to start getting IO therapy in the first line. And so it wouldn't be clinically salient for us to be enrolling a trial with patients that aren't what we're likely going to be seeing in the future. So what we're hoping for is TOPAZ-1 being reported in just a couple of months. That is going to change the landscape of how we can use IO therapy in biliary tract cancers. I hope that I've convinced you that biliary tract cancer is not a cold tumor, but we really do need to incorporate how we know the biology into how we actually treat these patients. And so what I'm hoping that we'll do is create a situation where we're able to classify patients into whether they have immunology responsive tumors, high mutation burden. If they fit in that high T-cell infiltrate group, they might have a different strategy than immunologically unresponsive tumors, and that we're able to use more sophisticated subclassification schemes to be able to really help our patients broad scale. And so my final conclusion is that in this rare tumor, we need to continue to refer people for clinical trials early and often. And with that, I'm happy to take any questions.
Thanks so much, Dr. Azad. That was great. Thanks to all of our presenters. So I'm going to open the floor for questions. I think we have microphones. Microphone over here. While we do that, Dr. Azad, so, because we now practice medicine by press release these days, if you have a patient who shows up in your clinic tomorrow and is not eligible for a trial, do you give Durva? And just to, further emphasize, the game change that this is for biliary tract cancers, the study that led to Gemcis over gemcitabine was published in 2010. So we've had over a decade of no progress in the frontline setting, and now, at least, by press release, we're anxious to see the numbers. This is a big change. So how do you approach patients based on that press release?
No, I absolutely would not add Durva at this point. We don't know the magnitude of the benefit. We don't know what the toxicity profile is in a larger study. We don't know if there's subsets that look like they really benefited versus didn't. We showed that data, Dr. O's data, that showed that the PD-L1 staining might be predictive of benefit. And so I'm hoping that that data is going to be presented. So we just don't know the details of that trial yet. And I hope some of those will come out in January, but they may not all even come out in January. Some of those details may still be remaining for more maturation. So I don't think it's fair right now and that may take away options for patients in terms of clinical trial options as well. So until we have more mature data, I wouldn't be comfortable.
Do we have a question in the room?
We do. Just to let everybody know, there are about 60 to 70 online as well, so you have friends out there. I listened to these three talks and came back with the same theme, and I think Dr. Azad ended her talk with this theme, and that is the molecular subcategorization of these patients immunologically. And even with Michael's talk about MSI, we still aren't even homogeneous in how we measure that, and yet we're sort of counting them all as the same. And so when and how do we begin to subcategorize patients for enrollment into trials and stratify according to arms based on is it an immunoscore? Is it something we can get from more traditional molecular testing? Because it feels to me that until we do that, we will continue to see these marginal benefits because they're, it's not enriched properly. Thoughts from anybody?
Yeah, so I have a lot of thoughts on this. I think that part of the challenge is that in order to use something for eligibility, you have to be able to, it has to be a CLIA level assay. And so some of these more sophisticated assays that are really exciting, I mean, we've been seeing this across tumor types, right? How many different papers have we seen that subclassified cancers into different subtypes based on RNA sequencing or genomics? Now, genomics, we have 1 million companies that are able to do that at a CLIA level. And so we are able to do these biomarker-based studies. So I think that's what it's going to take. And this is a little bit of the reality of clinical trials and of just practicing medicine, that until there are companies that are willing to do this, it's going to take a invested investigator who's able to develop a CLIA level assay to use some of these more sophisticated techniques.
Dr. Weiner in the room.
Okay. Hi. This is a question for anybody. Great talks. So we've known for quite a while now that immunoscores and things of that nature demonstrate that there's an association between T-cell infiltration and prognosis in patients with various GI cancers. Yet the checkpoint antibodies clearly have been somewhat disappointing, although with all the work described today demonstrates it's getting better. So what's being done to actually understand what it is that's defeating the immune response, since it's clearly relevant to these diseases? And are we doing a good enough job of exploiting those additional defense mechanisms in order to treat people with cancer?
Probably not. One of the limitations of biopsies is that we have only a snapshot in time of one spot in what's probably a heterogeneous tumor and only one metastasis. I don't have a good answer for how to address that. One thing that I would propose is doing a shotgun approach. If you have agents that are relatively well tolerated and you sort of cover as many immune escape mechanisms as you can, that's maybe how you get responses in these tumors where, like you said, the checkpoint inhibitors have been very disappointing.
And then, Dr. Overman, there's a lot of questions online that I'm going to try to kind of put together a composite question. So, in the MSI-H, realm, when we're seeing these patients in clinic, should we be giving single agents? Should we be giving doublet? How are we choosing, or can we use things like, does PD-1, PD-L1 have any real role in both the MSI-H setting or even the MSS setting and sort of how we approach the patients for immune therapy?
Yeah, I mean, I think, we had some nice discussion on both sides, right? MSI-H is definitely the place where we've had success. MSS, I think, immune therapy-based efforts are really, I would kind of strongly recommend clinical trial-based efforts to be further explored there, as I think the challenge of what combinations are still an area that we're working on, with hints of success that we've seen, but clearly need to do a lot more trial experience to understand what the right combinations are. In MSI-H, yeah, I think, that is the real question. I think, monotherapy has the randomized data, and I think that's probably the simple answer. I think the one high-level point that I would make, though, I think if we're really going for cure, one could make an argument to try to be more aggressive and consider combination therapy. I mean, we do a lot for cure in the adjuvant space, right? We treat a lot of patients, give a lot of toxicity for a small fraction of cure, and I think one can make the cross-trial argument that, potentially the cure fraction's higher with combination. Now, the one caveat kind of below that is that, could you salvage those monotherapy people that don't respond with combination, right? That's the counter that I just don't think we have good data for. Melanoma has some data that's actually, prospective, where, PD-1 progressors in melanoma, you have a good fraction of patients that have response to doublet-based therapy. So, but in MSI-H, it's anecdotal, right? So I think, fundamentally, I think both approaches are reasonable approaches. And so I think it's a little bit, again, kind of up to, the patient and provider. I actually do think doublet does make sense, but I think you have to have strong engagement with the patient, because you are, taking on the increased toxicity risk. And, immunotherapy toxicities are really, you need to have that communication line open between, the clinic and the patient to make sure you keep things under control and caught early.
And with the Pembro data, how do you predict who's not going to respond? Who's in that, 29%? Is it Lynch, non-Lynch? Is it RAS? BRAF doesn't seem to matter as much. What do you think? If you see one of these patients, what would steer you to be worried that they may not respond?
Yeah, no, great question. I mean, I don't know if we have a good, clean answer there, right? I mean, there's some sense that maybe RAS mutation has a little less benefit, but I'm not sure that's really that dramatic or that consistent. I think it's the question that I really frame is it really a, mismatch repair deficient or MSI-H patient, right? I think that there are cases where the PCR can be kind of, misread. IHC I've seen kind of misread. And so there are some cases where it does behoove you potentially to verify if it doesn't quite make sense. And that's where I do like next generation sequencing, because I do think you get that sense of mutation load. Clearly if you have something that's deficient mismatch repair on IHC and you get a NGS panel and they have like 2 mutations, something doesn't, jive, right? And I think that's kind of the space that I probably would say is the easiest kind of level to think of. The challenge there is, IHC is the quickest turnaround. You have that in front of you. And I don't think I would say don't act off it, because I think in the vast majority of patients, it is correct and a great test. But I think that is one thing to think about on kind of a second level.
I think we have time for one more question in the room.
Hi, I'm Azad, work for Boring Program. I have a question for Dr. Redman. So you're testing multiple agents like cancer vaccines and then 2-3 different agents targeting the checkpoint to activate the immune system. So what are your thoughts on, combining all these things, agent versus testing them in a sequential manner so that you activate the immune system in a systematic way? Do you have any thoughts on it?
Yeah, I agree. I think that the more combinations we can test in a rational manner, if something doesn't work, if 2 drugs don't work, we need to design trials that can then add a 3rd agent and a 4th agent that address the immune deficits that we think are there, or maybe it's a chemotherapy or a targeted therapy to give it a little more teeth. So I think those are the types of trials that we need to be doing in the future.